Greetings to all of you, and deep gratitude to the Florence Nightingale Foundation for hosting this virtual conference. My name is Jennifer Dohrn. I'm an associate professor and director of the Office of Global Initiatives in its PAHO WH Collaborating Center for Advanced Practice Nursing at Columbia University School of Nursing. I am a nurse midwife, and with the leadership of Dr. Ruth Lubick, I initiated the first freestanding maternity center in an inner city in the United States in the Bronx, New York. For over 20 years, thousands of women, primarily women of color, who had been excluded from early access to maternity care, participated in their care, had voices in the center's policymaking, and welcomed healthy babies. As an educator, I have directed the Master's Midwifery Program at Columbia University in the past, and now teach global health equity and the responsibility of the nursing profession to over 200 entering nursing students. This gives me a forum to engage with students in the global health disparities and racial injustices and nursing's ethical mandate to build models to eliminate these. I encourage the students to see themselves as agents of change and holders of the fundamental human right to health for all. I've spent over 15 years working in sub-Saharan African countries, helping to expand the role of nurses and midwives in primary and HIV care, and as the founding project director for the United States PEPFAR-funded ICAT Nurse Capacity Building Program, I initiated research with nursing colleagues in Amman, Jordan, on Syrian refugee women's views of their own reproductive health needs, conducted oral histories of nurses and midwives in Sierra Leone and Liberia on the front lines of the Ebola response, and now with nurses in New York City as they respond to the COVID-19 pandemic. I'm honored that my life's journey as a nurse defines my being engaged on the front lines around the world as we build bridges together. Today I'm going to speak to you on the front lines of pandemics, recommendations for effective response from the Ebola epidemic in Sierra Leone and Liberia 2014 to 2016 and COVID-19 pandemic in 2020 in New York. First, let me begin with a moment to honor all nurses around the world serving in the battle against pandemics, from HIV to Ebola to COVID-19, following in the giant footsteps and tradition of Florence Nightingale. The nurses in Eastern Cape, South Africa during the HIV pandemic, the nurses who gave their lives fighting Ebola in Liberia, nurses honoring International Nurses Day in Wuhan, China during COVID-19, and nurses in New York City preparing to begin their night shift. So the premise I begin with: for a robust response to pandemics, nursing is key to what works, what is essential, and what is achievable. Managing infectious disease outbreaks is one of the greatest challenges of our time, with heightened urgency in our increasingly interconnected world. As nurses, we are the largest cadre of the health workforce, frequently the only available providers, and too often bear the highest burden of death during outbreaks, epidemics, and global pandemics. At Columbia University, we ask the question, what do nurses on the front lines of pandemics recommend for guidelines for policy response based on their experiences? I led a multi-school investigation on the front lines, nursing leadership in pandemics, with the objectives of understanding and catalyzing the role of nurses as change agents in response to infectious disease, with specific focus initially on the Ebola epidemic in Sierra Leone and Liberia in 2014 to 2016, through recordings and analysis of oral histories, and summarizing and synthesizing the stories collected from frontline nurses and midwives to inform new policies, responses to detect, and effectively control epidemics on the front lines of healthcare. And this is currently been expanded to include nurses in New York City, United States, for a second investigation. Look at these beautiful faces of the nurses from Sierra Leone and Liberia, whom we had the honor of interviewing in 2019 for their oral histories. In August 2019, a nursing delegation with expertise in pandemic management from Zambia, from Malawi, and from the United States collected oral histories in the Ebola response And on left, it's our team meeting with Sierra Leone's Chief Nursing and Midwifery Officer, Mary Fulla, and on the right, meeting with Liberia's Chief Nursing and Midwifery Officer, Tarlo Kinwampa, to have their involvement and engagement in this. The results. We collected evidence from these oral histories, summary and synthesis. What did we learn? Criticalness of knowledge about and access to infection prevention and control measures. In Sierra Leone and Liberia, nurses repeatedly described the critical need for knowledge about the virus, its method of transmission, access to personal protective equipment. They reported that they had slow access initially to PPE and learning how to don and remove, and because of this, many became infected. One nurse told us, when we had this outbreak, I bought the PPE. I bought it with my own money. I bought the boots with my own money. I have my family. I have to go home and meet my family, so I don't want to infect my family, so I decide to buy these things. WHO, non-governmental organizations, ministries of health were initially overwhelmed with their stressed healthcare systems and Ebola virus's high fatality rate. Nurses reported that chief nursing officer, midwifery officers, regulatory boards worked to provide them with education and clear communication for nursing leadership to then teach at the clinical level. Matrons shared their knowledge around the clock with their teams, working as each shift came on to make sure that everyone was safe and protected before they entered the Ebola treatment units. The nurses bore the highest rate of mortalities amongst the health workforce. In New York City, nurses told us many similar things. They stated a lack of pandemic preparedness, both educationally and clinically, resulting in feelings of frustration at their competencies. And they reported that there were changing protocols for PPE and limited access to them in early months of COVID-19. They feared a shortage of PPE. And with lack of consistent national guidelines in the United States, states were left with the responsibility to provide PPE and guidelines, which caused great confusion and fear of exposure amongst nurses. Teamwork was redefined and changed for effective team response. Sierra Leone and Liberia nurses reported working closer as a team with doctors, with daily urgency loosening long-established hierarchical order. For example, the protocol for entering the Ebola treatment unit, everyone's lives depended on performing as a clear unit. They described meeting together in a circle, donning their PPE, checking to make sure each of them had no skin exposed, holding hands and praying together before entering the ETU. When they left the ETU, they repeated the same ritual. Nurses quickly became experts in PPE and taught others on the healthcare team. In New York City, nurses and doctors work as a close team in emergency departments and intensive care units. There's no time for written orders. Everyone worked at their highest level of education, and there was no compromise in quality of care. Nurses gave vital information, education, and care to their communities, our essential role as the link to communities. In Sierra Leone and Liberia, at first with little information given to communities about Ebola, nurses reported that they were stigmatized as people feared nurses might transmit the virus. As nurses engaged the communities and taught them about the virus, they were defended by the communities who felt empowered in infection prevention control. As they marched in the streets, they were greeted with, "Here come the Ebola nurses." Nurses stated that public health nursing and care for the community was a central part of their education. There was frustration that they did not have a designated responsibility as part of the country's pandemic response protocols. Nurses described their role as the critical link in communication between national leadership and the community, in translating and implementing safe burial practices, for instance, and providing primary health care services throughout the epidemic. In New York City, nurses described being called upon as experts to their communities to explain when guidelines were changed. Many said this was a new role in a healthcare that had given minimal attention to public health. Nurses witnessed great suffering and death amongst their colleagues, their families, their communities, resulting in mental and emotional distress. Every nurse interviewed described with anguish and tears witnessing the deaths of their colleagues, their family members, their neighbors. One nurse said, "I was gowned in the ETU and looked down to see my daughter being brought in. She looked at me and begged me not to let her die. I will never forget this." And she did live. On the right, you will see Fonte Buoga showing a picture of his late wife, Hawa Kamara, a midwife. She became infected first, then he became infected, all of their children and her family. From these infections, only Fonte and one of his children survived. Incredible tragedy. In oral histories recorded 5 years after Ebola, nurses spoke as if reliving events from yesterday. They had sought solace through their commitment to the nursing profession and through their faith, and many said they still had not healed. In New York City, nurses said they had no preparation for the volume of suffering and death they witnessed. Most did not know how to do post-mortem care as part of their education and practice. Nurses had constant fear of exposure and exposing their families to COVID-19. They grieved at going through the deaths of their dying colleagues. "My eyes are always going to be looking for them," one nurse practitioner shared. Nurses expressed dissatisfaction with the lack of acknowledgement for their services and sacrifices. In Sierra Leone and Liberia, nurses repeatedly said they had sacrificed as part of the nursing oath and loyalty to their people, and yet had not been adequately recognized fiscally, publicly, individually. And in New York City, nurses, in a different expression, said they were surprised and received satisfaction in their recognition in the news, in the communities, with 7 p.m. pot banging ritual from windows. "When I left my shift and walked outside the hospital, I was greeted with people cheering me. For a moment, I kind of felt like a hero," one nurse practitioner said. Nurses expressed dismay, though, at lack of recognition at the national level, where doctors were sought for expertise. Nurses wanted more involvement in policy and guidelines for pandemic response. In Sierra Leone and Liberia, nurses told of many missed opportunities for more rapid response because their voices had not been included at the leadership level. Leaders, for example, in infection prevention control training, which they could easily have done, decentralization for effective containment and treatment, and engagement of the community. In New York City, nurses expressed dismay. Their guidance for response continued to rest with doctors. Nurses are not sought for their own competencies in individual care and holistic care that encompasses of each person in context of individuality and community identity, the essence of our nursing profession. Nurses quickly connected with the COVID-19 pandemic in New York with the overall disparities in racism within the U.S. healthcare system, exemplified with the disproportionate number of deaths of Black people and people of color. I told my staff that I was going out to kneel in solidarity with those protesting racial injustice, and that any of them could join me if they wanted, one head nurse reported. From these, there are recommendations to inform new policies for pandemic response. First, disseminate rapidly knowledge about and access to infection prevention and control measures for new outbreaks to nursing cadre and the enlarged health workforce. A robust and resilient health workforce must be protected and maintained. 2, redesign framework for healthcare teams and their responsibilities with inclusive and flexible roles to maximize competencies and response. Nurses must have expanded roles in decision-making and provision of clinical care based on best practices and evidence. This can model ways for a new foundation for effective and just healthcare for all post-pandemic. 3, designate and capacitate nursing cadre as the link to community for engagement and education about transmission, prevention, treatment, respectful practices for community values and beliefs, and mobilization. There is no effective response without an engaged community, and nurses, we are educated and positioned to do this with knowledge and experience. 4, provide well-being services, physical and mentally emotional, to all cadres of the healthcare team during pandemics and afterwards. Nurses' resilience must be restored, supported, and protected. 5, recognize nurses' contributions and sacrifices fiscally, publicly, individually. And 6, inclusion of nurses at top levels in policy development, guidelines, and implementation of strategies for prevention, containment, treatment, and recovery. Arundhati Roy, Indian poet and activist, wrote, "The pandemic is a portal. The portal reveals the deep ruptures within our society and across the globe. It opens us to see what exists, its strengths and its challenges. In the United States, the COVID-19 pandemic has unmasked and exposed the reality of a neglected public healthcare system in favor of healthcare for profit, resulting in a delayed and ineffective federal response and too many deaths. And it has exposed the racial injustice, the legacy of racism, exclusion, and inequality historically built into and currently maintained in the U.S. system of healthcare. Globally, the pandemic allows us to see the potential and necessity for expanded nursing roles. These recommendations should be incorporated at global, regional, and country levels to inform global health policy. There is no more time for missed opportunities when so many lives are at stake. We need roadmaps for pandemic response that build healthcare teams with all of its members being supported to contribute at their maximum level and with every member of society receiving equitable and just care. And as nursing, we are ready to take our place." Here is a wall mural painted on the outside of our backup hospital saying thank you to all nurses outside of the hospital in New York City as they left their shifts. Thank you.